poll, oh, now I'm hot. The poll everywhere system. I just want to give you guys a second to log into poll everywhere. So the address, I don't know if there's maybe we'll have it up there at some point, but the address is pollev.com, pollev.com/AUA meeting 818. So that's interesting. So tell me, I'm glad I started early because I need to figure this out. So that's one option versus sending a text message is the other option? Text, okay, so we'll scratch that and we're gonna do the text message option. So the text message goes to 22333. If you send a text to 22333 and then the text needs to say AUA meeting 818. I'm not sure what the 818 is for, but AUA meeting 818. Oh, there's a slide. At that point, I see. I'm jumping the gun, but I figure, oh, there's that. Good. So I figure you guys can get booted up with that, well, because it's going to take a little while. We'll still wait a few more minutes to get started, but get that info up there. Thank you guys for coming bright and early. All right. Yeah, come on. I mean, looks more official that way. All right, well, good morning, everybody. Welcome to our course. Course, as you know, is entitled Genetic Testing in Prostate Cancer, Understanding Clinical Implications for Early Detection and Management of Localized and Advanced Disease. Again, we really appreciate you guys coming out at 7:30 on a Sunday morning in New Orleans. That's a tough task, and so thanks a ton. I've got a few things to read before we'll start with the intros, but here's the spiel. The AUA 2022 annual meeting mobile app is available and is free to download. When you download the app, you will be asked for a username and password. Use your email that you use to register. Your password is your AUA ID. You can find it on your registration badge. AUA policy states that all planners, authors, and presenters must disclose prior to their presentation all relevant financial relationships with any commercial interests. These disclosures are posted on the AUA's annual meeting website. For easy access, please visit auanet.org/annual meeting. Please remember to silence your cell phone. We won't be annoyed by that. It's actually fine. But no photos, video, or audio recordings are permitted. Really? Well, okay. I say take photos and put them on Twitter. Courses are selected based on evaluation results. So this is actually really important for us. We've been doing this course for 5 years now-ish. Yeah, so we really enjoy doing this course. It actually makes a big difference. We get the evaluations, we take a look at the evaluations, and the AUA takes a look at the evaluations when they make decisions about the next courses for next year. So please, please, please fill out those evaluations. You'll also, I think at that time, have a chance to do the post-test. We're going to have a pre-test. There will be a post-test, and I've got the post-test spiel that I'll remind you guys at the end. But if you happen to need to leave early, just know that there's a post-test. It's really important also, both for data keeping and hey, come on in. Good morning. And again, for kind of making changes to the course for next year. I'll put, when we get to the pre-test questions, I will put the info again up on how to do that. So in terms of, do I have, oh, here's this, great. So here are our disclosures. I want to put these up there for a minute. Dr. Gamella's the advisory board for AstraZeneca, Merck, Exelixis, and Pantheism. For myself, advisory boards for Tempus and Myovant Biosciences. For Dr. Cheng.
I think pantheism sounds like a disease.
It's actually, I looked up pantheism.
It's a disease?
No, it's actually, there's a whole Wikipedia page on pantheism, and it's, do you know what it is? It has,
Sounds like a religion.
it is, but it has something to do with religion, but it's some take different from atheism, say, but somebody can Wikipedia that, and that's the word of the day is pantheism, but I couldn't find the company. I was really curious what that is. Dr. Cheng, research funds from Clovis, Color, Janssen, Medivation, Boss Platin, and Sanofi, and consultant for AstraZeneca. And so those are obviously very important to mention. Faculty, myself, I'm Todd Morgan. I'm a urologic oncologist at the University of Michigan. Ted, that's when you say go blue. But you missed your chance. Great to get to be here this morning with all of you. Dr. Lenny Gamella, who's chair of urology at Jefferson University, Jefferson Health in Philadelphia, amongst many other senior roles there, and really expert urologic oncologist in germline genetics. Very grateful to be able to work on this course with you over the years. And the true guest is the non-urologist, the medical oncologist, Dr. Heather Cheng, who came all the way from Seattle just for this morning. And truly, we cannot thank you enough for coming for this. Dr. Cheng is big-time expert in germline genetics, especially in advanced prostate cancer. Brings just a wealth of expertise, directs the prostate cancer genetics clinic at University of Washington / Fred Hutch Cancer Center. So thanks again for making it here. It's amazing, and it's really early West Coast time right now. Okay, so here's one more time is the text, the way to get the poll everywhere questions. If you're just walking in, please send a text to 22333, and the text should say AUA meeting 818. Again, this is really important. We're going to do the pre-test. Later on, there will be a post-test. Those questions are really valuable for us as course faculty. They're really valuable for the AUA. I'm stalling a little bit while you guys do this, because I know it also takes a few seconds to get registered. All right, so, wow, we have a surprise question. Great. This is more stalling, I guess. What do you love most about New Orleans? A, AUA 2022, of course. B, Creole and Cajun food. C, Bourbon Street. D, the French Quarter. Yeah, so then we have to stall until we get up to 20 or something. So please do this. Keep stalling. Takes too long, I start telling dad jokes, so I'm gonna wait. Ten is progress, but I'm still waiting. Still, I'm going to keep stalling. All right, so my son told me he was really cold the other day, so I told him to sit in the corner because it's 90 degrees. That's the kind of bad joke I got, so please keep filling this out. All right, so we'll go to the actual pretest. Number 1, the gene most clearly associated with increased risk of aggressive prostate cancer is A, BRCA1, B, BRCA2. Oh, I'm supposed to do this on the next slide, actually. A, BRCA1, B, BRCA2, C, ATM, D, MSH2. There we go. All right, next one. Question number 2. Which of the following statements is false regarding genetic testing of prostate cancer patients? A, criteria for consideration of genetic testing includes family history of breast, ovarian, pancreatic, and colon cancer. B, testing can be performed with blood or sputum. C, multi-gene panel testing is covered by some commercial insurance providers. D, when somatic tumor testing has been performed, germline testing is unnecessary. And again, if you're just coming in, you can join, oh, there it is right at the top. Join this text, AUA meetings, 818 to 22333. Great. All right. Long question. A 64-year-old man presents with metastatic prostate cancer. He has started ADT and is considering abiraterone versus docetaxel. You perform pretest counseling and order multigene testing in your urology and or oncology clinic. Test results reveal a germline BRCA2 mutation, pathogenic variant. Which of the following is false? A, it is critical to refer to genetic counseling for appropriate follow-up and cascade testing of family members. B, it is critical to refer to genetic counseling even if he has only sons. Tailored clinical management should be considered for men with a BRCA2 mutation. C, based on current data, the presence of germline BRCA2 mutation should lead to prompt consideration of adding a PARP inhibitor and avoiding abiraterone or docetaxel in the hormone-sensitive metastatic setting. D, based on current data, the presence of a germline BRCA2 mutation should be noted for clinical trials and future consideration of PARP inhibitors if he develops castration-resistant disease. Long question. I'll give you guys a few minutes. No, not a few minutes, but longer. All right, there we go. Got 16. We'll take it. 17. Awesome. All right. Pretest question number 4. Which of these treatments may be particularly effective for men with Lynch syndrome who have metastatic prostate cancer? Olaparib, pembrolizumab, cisplatin, or enzalutamide? There we go. Olaparib, pembrolizumab, cisplatin, or enzalutamide. Shorter question. All right, we did it. Okay, so now we get to start with the brief intro, so what are the learning objectives here? 1, we're going to talk about counseling men with BRCA1, 2 mutations, Lynch syndrome, and other key inherited syndromes regarding their prostate cancer risk and appropriate strategies for cancer screening. I'm going to describe the criteria for genetic testing of prostate cancer patients, the gene panels available, and options for testing these men. And we're going to talk about how do we interpret the results of genetic testing and relay this information to patients in order to facilitate shared decision-making based on the test results. Finally, we're going to talk about how do we utilize these results to improve outcomes among patients with prostate cancer. So these are the objectives that we hope to cover, that we'll cover. And first, just like the big picture, step back. Why do we consider germline testing? Why are you guys here today to talk about this? Well, we think about this for risk assessment, right? For any biomarker, risk assessment. We're often talking about what is the probability of somebody developing cancer? What is the probability of somebody developing aggressive cancer? We think about prevention, and we don't think about that maybe enough for prostate cancer. Is the disease risk modifiable? So can we identify patients at particularly high risk, and can we modify that risk? Again, for just about any biomarker, we're thinking prognosis. Does the germline alteration have an impact on prognosis for affected for men with prostate cancer? Which mutations? Treatment selection. So are there treatments that are more or less effective in the setting of a specific mutation? And so here the term we often think about is a predictive biomarker. So we think about prognostic biomarkers that can, these are like, say, the Decipher test that people often use in localized prostate cancer, which is a prognostic biomarker, tells us about risk stratification, but doesn't necessarily tell us what treatment is going to be best. And so for germline mutations, are there mutations that might tell us which treatments work better? The answer is yes. And then finally, the familial risk, familial testing. This is a really important aspect to genetics. This is different than all the other biomarkers that we talk about, because we're not just talking about the patient in front of us, but we're talking about family members that also may be at risk, that also may need testing. And so these are some of the real key reasons why germline testing is important, and why, again, thanks for being here, and we hope to really cover all of this ground. In terms of the agenda, I've got my introduction that we just completed. Dr. Gamella is going to go through the basic concepts and overall impact of prostate cancer screening in the context of germline mutations. We'll take some time for Q&A. Please don't be bashful with questions. I will give a talk on the implications of germline testing and localized prostate cancer. Again, we'll hopefully take some time for Q&A. And then last, Dr. Cheng will talk about the implications of germline testing in advanced prostate cancer. So that's the game plan. And for that, I get to hand this over to Dr. Gamella. Thank you. Thank you.
Thanks, Todd. Thanks, Todd. Again, welcome everybody. You guys should get double credit for being here on a Sunday morning in New Orleans at 7:30, so thank you for joining us. And also I want to thank all of you for being here, because this is really one of the cutting-edge areas in the future of prostate cancer and urology. This is something precision medicine-centric. And the fact that you all are here means that you're going to be really on the next wave of things. Robots, yesterday's news. Genetics, genomics are really going to be the future of everything that we're going to be talking about in all diseases, but the big one today is really prostate cancer. So why are we interested in this area? Well, something very interesting happened in 2003. After 13 years, the NIH was able to map the entire human genome of 3.2 billion base pairs, and made a big deal about this. I mean, this took 13 years to accomplish. But a little thing also happened this year, that they completed the sequence of the human genome. What they didn't tell us was back in 2003, they had gotten like 92, 93% of the genome, which they considered to be like the end-all be-all, and it was really just this year that they actually completed the whole genome sequencing. We haven't seen too much in the prostate cancer world right now, but this is a rapidly evolving field, as I'll show you in a moment. Well, things were pretty quiet for about 10 years, and then two very important things happened in the field of medicine. The first was Angelina Jolie and her public discussion about having an inherited genetic risk for breast and ovarian cancer. And I think really she deserves a lot of credit, because this is the first time I think the public was really aware of the fact that there could be a gene passed down from different generations to increase the cancer risk. But another interesting thing happened that same year, And that was one company for essentially 10 years had the lock on BRCA1, BRCA2 testing. But eventually the Supreme Court decreed that no company could really patent a naturally occurring or mutated gene. So that's why everything then really started over the last 8 or 9 years with many other companies, other technologies getting involved with genetic testing. Now, to put a little bit of things in perspective, how rapidly this is happening, and also what's the implications that we now have for prostate cancer screening, before 2016, you could not find any information in the NCCN guidelines about prostate cancer unless you looked at the hereditary breast and ovarian cancer guidelines. In those guidelines, our medical oncology colleagues like Dr. Cheng and others identified the fact that, you want to know what? Ladies who have male relatives, they may also have this gene that may increase their risk of having prostate and male breast cancer. It was in 2016 that for the first mention that in the NCCN guidelines, if you've got a family history of BRCA1 or BRCA2 positivity, it should be considered in the screening algorithm. Well, by 2017, it was baked in there. It was really the first familial hereditary genetic considerations. 2018, they talked about considering germline testing based on the risk, and the bottom line, by 2020, it's now baked into the guidelines. Germline is recommended based on the risk when you do a familial family tree. So at Jefferson, the Kimmel Cancer Center, we've been very proactive in this area. In fact, we've had 2 international consensus meetings with my colleagues here also participating. The role of genetic testing in prostate cancer, we brought together a collected group of individuals from medical oncologists, geneticists, ethicists, basic science researchers to come up with some general guidelines or recommendations about how to approach this topic. So what I want to do in the next few minutes is sort of set the stage for the things that Dr. Morgan and Dr. Cheng are going to talk about, run down some basic concepts that will allow you to really go further into the important concepts that Todd and Heather are going to talk about. So what I want to do is kind of bring you back to high school biology, talk a little bit about some basic science and molecular biology when it comes to screening. So when we talk about genetics, it's traditionally the study of individual genes. You know, we all did those fruit fly experiments and those things back in college. But traditional genetics has really now moved forward to the concept of genomics. So the word genome refers to the entire set of genes in an organism. But today we kind of use the term genomics and genetics interchangeably because it's much more complex. And we don't usually talk about one gene, but the interaction of many different genes and in the environment causing a variety of diseases, including prostate cancer. So again, everybody knows the old Watson and Crick DNA base pairs, AT, TC, GC, GA, and basically all our cells, except for red blood cells, have the 23 chromosomes. Turns out, though, and this is the interesting thing about mapping the human genome, most of our DNA is actually non-coding. Probably 80 to 90% is what we call dark DNA. We really don't know what it's doing, and this is going to consume researchers for many, many, many years. Terminology-wise, BRCA1 is a naturally occurring gene, but when we say mBRCA1, for example, it refers to the mutated one. So most of the genes we're going to be talking about actually are going to be mutated genes today. A little bit more basics. Exons are the sequence within a gene that makes the RNA transcripts, that basically makes all the proteins in our body that make us a unique organism. Introns are that dark part of the DNA. We don't really know what's going on, and actually the majority of our DNA is an intron that really doesn't code for protein, but must have some other impact on our existence that it's being looked into. I'm just going to mention the concept of SNPs, or single nucleotide polymorphisms, because there's a little bit of confusion, the difference between a SNP and germline and somatic mutations. And really, SNPs are just these variations in the DNA that give us different eye color, different hair color. And I think the term of polymorphism is if you see this change in at least 1% of the population. And basically, right now, this is really used mostly for screening purposes. And the crosstalk between germline testing and looking at hundreds of different subtle changes in the DNA sequence known as polymorphisms are something that's going to be an area that we're going to be learning a lot about in the future. And lastly, you hear the word epigenetics. And basically, what is epigenetics? Basically, that's an on and off switch for the gene. It's not actually a change in your DNA sequence, but methylation happens, and it's sort of like an on-off switch. Certain parts of the gene are turned off when they get methylated, and that's what the term epigenetics is. Again, not to talk much about it, but I wanted to give you guys some background when you hear these different terms used. So we all are familiar with karyotyping. Karyotyping has been with us for the last 30 or 40 years. At karyotyping, you can determine major chromosome breaks, but you can't see the subtle ones that we're going to be talking about going forward, talking about genomic changes, talking about changes in DNA sequence. So most of the chromosome DNA changes in cancer are not detected unless you use these very exquisite molecular techniques that we're going to talk about. We could not do this if it was not for computational biology. Here's just an example of a normal BRCA2 gene. This image is one of small area. This is 12 pages long. This is the magnitude. This is why we're talking. It took them so long to sequence the human genome, because you have to go back and make sure you're not making mistakes. And that's the big problem, and that's why it took 13 years for different techniques to develop, and we'll talk a minute about next-generation sequencing and how that has become so important. But when you talk about mutated genes, there's not, and this is a big issue. This is where we get involved with, and I don't want to go off too much on the what I call recreational 23andMe, but they don't really necessarily do a deep dive. 23andMe, some of those recreational genomics that patients could just send their saliva, they're not looking at hundreds and hundreds of BRCA genes, for example. And I don't know, I have a little bit of problem with that, and we'll see if Dr. Cheng or Dr. Morgan have a problem with it. They just look at the 3 founder genes, for example. And so if a patient gets a buccal swab, send it off to 23andMe, they get a negative screen. Well, that's just for the major genes. A real genetic testing company will look at hundreds and hundreds and hundreds of potential alterations in the gene. So remember, there's just not one mutated BRCA1, BRCA2, ATM check, whatever it might be. There are actually hundreds of them out there, and it gets quite complicated. So this term deep sequencing, you probably hear it, next generation sequencing. This has been the magic bullet that allows technology to rapidly interrogate a sample, and this is something that developed over the 13 years of the NCI Genome Project, and this allows essentially very rapid sequencing of large numbers. And in fact, 10 years ago, if we were in this area, we might just order one BRCA1 or one BCR2. Today, panels are the way to go. You get a large number of genes. Once you put that chip in, you can get hundreds of different genes, as we're going to show you in a couple of minutes. This is kind of my spin on modern tumor evaluation, going from imaging to gross pathology to histology. Well, now we're down beyond the chromosomes, and molecular pathology is one of our big areas in the field of medicine. We're actually getting molecular reports beyond just the histology, but very specific genomic sequences. Now, this is probably the money slide. And I would be so happy if I saw you in 2 weeks, you remembered this slide. The concept of germline versus somatic mutations. Most of what we're talking about today in this first part is going to be about germline mutations. And later on, when Heather gets into therapeutics, she's going to be talking about both of these concepts, both germline and somatic mutations. So germline mutations are what you get from your mother and father. They are inherited. They may be in your siblings, depending on how the genes cross-pollinate each other. Somatic mutations are what I like to call the Wild West of the tumor. Anything can go wrong in a tumor. It might not necessarily be inherited, but you can have all sorts of genetic alterations that show up in the tumor, but don't show up in the inherited germline. And as we'll stress over and over again today, When you're doing somatic testing of a tumor to look for genetic alterations, you really need to do both genetic and genomic testing, because sometimes the germline may show up in the tumor, and sometimes in the tumor you may get a completely different panel of mutated genes. So again, the tumors may also have the germline mutation, but it's important to remember they also may have their own independent mutations present. Now, these are kind of three buckets I like to look at: inherited testing, genomic profiling, and then genomic tumor sequencing. The one in the middle is one that urologists are generally familiar with. This is genomic profiling that looks at specific proprietary molecular signatures, not necessarily germline, not necessarily somatic, but it's their proprietary Decipher, Polaris, Oncotype, Confirm, and these have been used by us in urology for many years for treatment decisions. We're kind of not really talking about that today. What we're talking about is either things that you get inherited from your family or things that happen in the tumor. So for example, most of what we're going to talk about is the inherited cancer testing, where you look at genes that you may have inherited from your parents, either by a buccal smear or by blood testing. And we're using these today for screening. We're going to talk about cascade testing of other members of the family. And it also helps us to decide for treatment and clinical trials. The other one is genomic tumor sequencing. This is really a hot topic right now in oncology, where you go in, you get a biopsy of the tumor. As we'll learn later, the PARP inhibitors are all pretty much based on this concept of genomic tumor sequencing. Now, one of the big areas carrying on right now is liquid biopsy. And what is that? That is identifying circulating cell-free DNA that's being shed by the tumor. So while a lot of somatic tumor biopsies are done with a needle biopsy of a liver met, a retroperitoneal node, etc., we can also today use some technologies that may help us if you don't have a large tumor to biopsy in a patient with metastatic resistant cancer. You can usually do a liquid biopsy. So this somatic testing concept is something that has been used extensively in the development of drugs, and essentially you send this sample off to a company such as Foundation or Caris or one of the other companies, and they look at a whole panel of genes. They look at all these different genes out there. You see many of them that we're going to be talking about: BRCA1, BRCA2, ATM. It's a complete panel. Remember, they're looking for the Wild West of the tumor. They're looking for anything that might be in there that may help direct testing. On those reports, you hear about other things known as tumor mutational burden, as well as hearing about microsatellite instability. We'll talk about at the end. Those are other factors that today might allow you to practice precision medicine and, for example, treat a patient with metastatic prostate cancer with pembrolizumab, for example, but it has to be based on this somatic testing, and again, we'll talk more about it. So again, tissue biopsy is most common. Liquid biopsy is becoming very hot, and this, again, identifies what we call actionable mutations. What are they? They are mutations that tend to respond to a specific therapeutic agent. For example, the PARP inhibitors may be active in about 20% of cases of metastatic castrate-resistant disease, and they look at what's known as the homologous repair genes, which we'll talk about in a minute. And of course, pembrolizumab is out there. I mean, really, the Pembro is now got, I think, about 17 or 18 different indications in tumors, but we can use it in prostate cancer if you meet these criteria of mismatch repair genes, the Lynch syndrome genes that are noted there, and other issues. So this is a very hot area right now, is liquid biopsy. And there's a lot of work that's been done in this area, and while it's not perfect, there is a high concordance between what's going on with matched tissue biopsies and matched circulating cell-free DNA. Basically, you've got DNA from the tumor circulating in the bloodstream, and that can be captured. So it gets a little tricky for reasons that maybe Heather will talk about, but the bottom line is this is a rapidly evolving area and maybe a lot easier than sending somebody to IR and, biopsy a retroperitoneal lymph node or something like that. One other concept I just want to touch on is this issue of microsatellite instability. Very important today if you're going to put a patient on pembrolizumab. Microsatellites are these repeated DNA sequences that occur. And when there's a problem with our DNA germline, the genes that protect our integrity of our DNA, you might end up with something called a mismatch repair. And if you have a very high level of microsatellite instability, it means you've had a lot of problems with your DNA repairing itself when it goes to duplicate. And microsatellite instability, if it's high, is one of the indications for a drug such as pembrolizumab. So when you test for germline mutations, and I'll be the first one to step back and tell you that I am blessed at Jefferson and the Kimmel Cancer Center, where we have great genetic counselors that we work with. To me, I think I'm a little uncomfortable making a lot of recommendations, but we rely a lot on our genetic counselors. But I think as urologists, we need to understand these concepts. When you do a germline mutation, you may get different results back. You may see something pathogenic or likely pathogenic. You might see something benign or likely benign. But the tricky one here is the VUS, the variant of unknown significance. And you will get this back when you send some patients off for a buccal smear and a germline test. What does that mean? These VUSs are in our NCI gene bank, and they're identified sequences. Somebody at University of Washington or Michigan identified this new DNA pathway, let's say for BRCA1, they send it at a gene bank, and over the years, that is looked at, and eventually somebody will determine, hey, you want to know what? This is not really a pathogenic gene, so it's probably okay. But this is one of the tricky subtleties you get involved with. If you're going to start to order genetic testing, understand that you may get a report back such as VUS. And what does that mean to you? You need to follow that patient, because 6 months later or a year later, they may come back with a change. And lastly, just for completeness sake, the polygenetic risk scores. These look at the SNPs. These are not mutated genes, but those are the variations that we have in our genes that we talked about. Right now, there's been about 140 or 150 SNPs that are associated with prostate cancer. You see how they're identified: TRMT11, WBSCR2. These are, again, not pathogenic genes, but just certain changes in our DNA that may increase the risk for prostate cancer. Next, let me talk about prostate cancer inherited risk. At the end of the day, only about 10 to 15% of our patients have an actually clearly identified mutation. In other words, there's no doubt that grandfather had prostate cancer, the father has prostate cancer, and the children have prostate cancer. That is only in about 10 to 15% of our cases. However, when we identify that, it completely changes how we should approach those patients. The next category here, which is again about 15 or 20%, are familial. Familial is, it kind of smells like there's something going on in the family. You know, you got two sisters with breast cancer, maybe the father had prostate cancer, but you can't identify a clearly inherited gene at this point in time. So we put that in the familial bucket. Lastly, sporadic is still most of our prostate cancer patients. You can't find an inherited germline mutation in those patients. However, when you find a hereditary gene, it's very important. Another important concept I'd like you to leave here with today is that these mutated genes do not cause prostate cancer, but they increase your risk of prostate cancer for reasons that we'll talk about. So again, they don't cause prostate cancer, but they allow whatever trigger starts prostate cancer to go on unabated. But remember, these genes that we call pathogenic genes also increase the risk of other cancers in the individual and in the family: breast, ovarian, pancreatic, male breast cancer, and the like. So again, as we mentioned, we do genomic and genetic testing to to make decisions about screening, but also for some treatment options. This is sort of a short list, and as Oliver Sartor talks about, there is a very long tail of many prostate cancer-associated genes out there. However, these are kind of the big dogs: ATM, BRCA1, 2, check. If you look at the mechanism, almost all of them are involved with a dysfunctional DNA response pathway that heals your DNA when there's a problem, when your DNA replicates. So most of these genes are associated with something wrong with DNA repair pathway mechanisms. I point out the HOXB13 because that's the really inherited gene that is most identifiable in those groups of men under the age of 50 or 55, where every man in a family just about has it. That's got something to do with the androgen receptor pathway, but that's very, very, very rare. The common ones that we see all have to do with DNA repair. So here's this concept that we're talking about. All of these genes that we're talking about are involved in the DNA damage response and repair pathway. And our DNA really has an incredible ability to maintain itself and protect itself. But once you have one of these mutated genes that normally goes in and helps the DNA repair itself or replicate itself in exact copy, once that gets messed up a little bit, that's when you start to get genetic predisposition. And when one of these DNA repair pathways is altered because of a mutated BRCA1, BRCA2, your DNA repair starts to go a little bit haywire, and that's you end up going from a precancerous state to a cancerous state. And these are very common in prostate cancer. This is another one of the most important slides that I'm going to talk about this morning, germline mutations in metastatic prostate cancer. This is actually Colin Pritchard, who Dr. Cheng knows very well, who is her life partner out in Washington, who also is a major researcher in this area. And this important paper really told us that if you look at germline mutations, inherited alterations in these genes increase the risk of metastatic prostate cancer, and again, castrate-resistant prostate cancer. The early studies talked about 11 or 12%, but as time goes on, that number is creaking towards 20 to 25%, the more genes that you look at. So again, these BRCA mutations that are mutated, again, we're going to use them as the model. They are DNA damage response genes. When they're mutated, they can't keep the integrity of your DNA well going forward. If you've got one of these mutated genes, you've got an increased risk of developing prostate cancer, increased risk of developing high-grade metastatic, and sadly, ultimately dying from prostate cancer. So this may be only 10 to 15%, maybe 20% of our patients, but when you identify this, it requires very specific attention on that family. And remember, it also increases the risk of the individual for developing other cancers as well. Anybody who doesn't believe this, this is a very nice paper out of Hopkins from Bill Isaacs about 6 years ago now. This is a long timeline across the bottom, but you can see if they've got a germline mutation in some of these genes, you can see the dramatic decrease or increase in mortality of these men. That is a 10, 15, 20, 25-year life expectancy. So again, we got to treat these genes respectfully. They are potentially life-threatening. About 1 in 400 patients carry a mutated BRCA1 or 2, and again, if you happen to run into a partner that maybe has a gene as well, you might increase your risk of having this. But again, there's no question that breast cancer is eons ahead of us. And breast cancer, remember, BRCA refers to the breast cancer. That's where the BRCA1, BRCA2 comes from. So they know a lot more about it. But you can also look at the incidence of mutated genes in breast cancer, extraordinarily high. Not so high for prostate, but you can see elevated for pancreas and male breast cancer. So again, the impact of these genes in breast cancer is massive. It's not as significant in prostate cancer, but when you identify, it's very important. Remember, these inherited mutated germline genes also increase the risk of family members with the gene, as we talked about, not only an individual, but other family members. Next, a little bit on practical considerations. Today, we have some very nice companies, and this is, again, just a partial list that's out there. Commercial labs pretty much have the same genes that we've been talking about. There are some general cancer panels at the bottom that are not specific for prostate cancer, but if you order one of these gene panels, they also tend to include most of the prostate cancer genes. We are very lucky at Jefferson, and again, I would not know anything about this unless it was from my colleague, Dr. Vita Giri, who joined us at Jefferson about 7 or 8 years ago, who brought us to the modern era. We incorporated this in our multidisciplinary clinic, and we've been offering preliminary genetic screening for our patients who come into the clinic since about 2014. We don't test them when they walk in because they're there for treatment decisions, but we sort of plant the seed and we talk to them a little bit about once your treatment's over, particularly for localized disease, we'll come back and visit. A little different when they walk in the door with metastatic prostate cancer, we tend to be a little bit more aggressive about the screening. But my colleagues here, Todd Morgan up at the University of Michigan, they also have risk clinic stratification, where they look at looking at these different factors, including some of the molecular diagnosis that we talked about to decide how to approach patients. And likewise, Heather's really been leading this charge with some nationally funded and aggressive programs to really identify men with metastatic cancer. And I know Heather will probably talk a little bit about that, but working on getting this all across the United States, the opportunity for men to have genetic testing and counseling. Just a few comments about counseling for inherited cancer risk. This is where our genetic counselors help us so much. They really sit down and do a deep dive with the patient and talk about a lot of factors, including family history. So this concept of cascade testing, when you identify a certain pattern of men with different DNA, with different tumors, either in men or in women, again, we bring forth this concept of cascade testing. Once you identify a man with the gene, who else in the family should be tested? And this is where it gets a little tricky, and this is where you really need a genetic counselor to work with you. The other thing I need to mention to urologists is this concept of the GINA Act, Genetic Information Non-Discrimination Act. You have to be very careful. When you have a patient with metastatic cancer, you've identified a germline mutation. That is very important for that patient, but you have to be careful how far out you go on the family, because while GINA prohibits genetic discrimination in health insurance, it doesn't protect an individual in life, disability, or long-term care insurance. So you got to be a little bit careful when you go on the pathway of cascade testing of other family members. What is the implications? And lastly, just a few comments about the emerging role of genetic testing in prostate cancer. This is the laundry list of different things that we're doing now with screening. We're using it for active surveillance in selected cases, treatment decisions, precision medicine. So this is the future. This is where we are with prostate cancer going forward. So why is germline and somatic testing important? Risk assessment. Does this patient have aggressive disease? Is this something that other members of the family should be tested? Prevention, we're not there yet. But again, concepts of developing prevention strategies in patients with known BRCA1 or BRCA2 mutations. Prognosis, absolutely critical, and Todd and Heather will talk a little bit more about this. And lastly, precision medicine. We need to do somatic testing to individualize treatment for our patients. This is a long list of when you should consider genetic germline testing or counseling. The big ones I want to point out in NCCN guidelines, absolutely anybody with metastatic prostate cancer, either at initial presentation or when they develop castrate-resistant disease. High-risk localized cancer, intraductal or cribriform. Also, if you've got somebody with 10 out of 10 cores with a Gleason, 4+4 prostate cancer should be considered. And Ashkenazi Jews, the reason that's important, BRCA1, BRCA2 were first identified in the Eastern European Ashkenazi Jewish population. And if someone has some Eastern European roots, that might be something you want to think about with the testing, and of course, other cancers in the family. So from the basic concepts that I'd like to set the stage for Todd and Heather, very rapidly evolving recommendations and decision-making. Remember, it's only been the last 3 or 4 years where these have actually been in our NCCN guidelines. We identified the most critical genes today, but there's a lot more genes out there, but these are the most common ones. There was a high prevalence of germline mutations in men with castrate-resistant prostate cancer, as Heather's husband first described several years ago, maybe up to 20 to 25%, in fact, of men with metastatic castrate-resistant disease. All metastatic patients, localized, high-risk patients, de novo metastatic patients, and certainly castrate-resistant should get germline testing. Somatic testing, remember, is complementary to germline. So if someone is in 3rd line or 4th line treatment for prostate cancer, they really should probably have somatic testing of the tumor. Again, liquid biopsy becoming increasingly common. Urologists are not doing too much of this. Certainly medical oncologists are taking the lead, just something to be aware of. And again, genetic counselors, I think, are very essential. And again, there's a lot of work being done on developing better prostate cancer genetic panels that are out there. So again, I thank you very much for your attention and being with us this morning.
This is on. Oh, good. Hey, that was awesome. Thank you. Wow. I love following your talk because it just like it just sets everything up.
It sets it up.
It sets it up.
I make it
do
easy for
you.
you.
Do.
So that's why they bring me in. They make
It is.
easy for
That's
Dr.
why. That's what I need. Yeah. You just cover it's the foundations of everything that what comes from that framework is how we apply this to localized prostate cancer and how we apply this to advanced prostate cancer. We do have a few minutes. Any questions, please come to the mic if you're thinking about questions. And we got a couple minutes. I have a question for either of you, which is, so let's say a patient comes in, they've had 23andMe, and they say, oh, I've got a BRCA mutation based on 23andMe. I mean, how does your genetics group address that, or either of yours?
I'll let Heather go first because they have a dim view of 23andMe, but I'm biased against 23andMe when it comes to medical decision making.
Yeah, I think that what Dr. Gamella said, and we've alluded to, is exactly right, which is 23andMe is a recreational test, and it's absolutely insufficient for any medical purposes. So I would just think of it as totally different, not adequate. Might give you some clues, but really is not sufficient at all. So really,
so you do confirmatory testing with a standard test, right?
They have to have real genetic testing, not the recreational one.
Please.
I've got one question. Could you elaborate how the connection between the DNA repair pathway and the hormonal axis is? Because I was wondering why breast cancer, prostate cancer, they're all hormonal active cancers, how they're connected to the BRCA DNA repair pathway.
So let me. So you're asking. How do DNA damage repair genes drive prostate cancer? When we think of the context of prostate cancer usually being AR driven.
Yeah, for example, because when you just think of theory, this repair mechanism of BRCA is also should be also active in other cancers. But when you look, it's only certain cancers, and some of them are hormonal active, like also breast cancer. So I was wondering, by you are all experts, how the connection is, because I don't see it directly.
Sure. Either of you guys want to take a stab?
I think it's kind of speculatory. I think you're asking a great question that many, many other people are also wondering, and many really, amazing scientists are also interested in studying. I mean, I would hypothesize it could be that these are organs that are hormonally driven, and so, there's periods of extreme growth and then periods of quiescence, and that probably is a biological process that makes you more vulnerable to, if there is a tendency to DNA damage repair. Essentially, when an organ is in that process of rapid growth, it's going to be more likely to sort of take off. That's speculation, though.
Can you do a germline testing in a liquid biopsy, or have to be only tissue diagnosis?
I think Dr. Morgan's probably going to cover that, so.
Oh, okay.
Great question, though.
I missed the question, but whatever it is, I'll cover it.
Can we do germline testing from a blood test or?
Ah, great. So from germline testing from a blood test, we were gonna cover this. Great. So the purpose of this talk is really to, again, take the foundations that we have from Dr. Gamella and apply it. And the key questions that I want to look at are which patients with localized prostate cancer should undergo genetic testing? How do we implement genetic testing? And should we treat patients with low-risk prostate cancer differently if they have a BRCA mutation? And should we treat patients with high-risk localized prostate cancer differently? This says BRCA mutation, but I would also say really any DNA damage repair mutation that we find on genetic testing. And again, this is framework that Dr. Gamella already presented at some level, but it's really important. So we have, genetic predisposition in many ways. We have all these common variants we think of as SNPs, and people learn about these through these so-called GWAS, genome-wide association studies. So tiny little changes, tiny little effect size for each of these mutations. Then higher up, we have these rare, uncommon variants like BRCA1 and BRCA2. So they're less common, but they have a greater effect. And then in some diseases, not prostate cancer, there are very rare variants that have really large effect sizes. And so this is kind of the pyramid of genetic risk in general. And it turns out that they, like all of these things are really important in prostate cancer, and they're independent of each other. And so this is I think a really good study published a year ago that said, okay, let's look at family history, let's look at rare pathogenic mutations, a few of them. So that's RPM, is like BRCA1 and BRCA2, CHEK2 is in here. And then let's look at GRS, a genetic risk score. So this is like the combination of SNPs that Dr. Gamella talked about. And each of these is predictive of prostate cancer incidence and mortality, and each of these is independent of the other. So, we really have to think about how do we apply this in the context of those kind of three different domains of heritable risk. And then this study is really cool and shows kind of a similar effect. So it said, okay, let's look at a huge number of patients, and we'll look at patients, and we'll look to see if do they have one of these rare pathogenic mutations like BRCA1 or 2. And let's also look at their genetic risk score here, polygenic risk score, so a bunch of SNPs together. And in here, dark blue are the non-carriers of the, say, BRCA1 and BRCA2 type mutations, and light blue are the carriers. And odds ratios on the y-axis of developing prostate cancer. And then on the x-axis is increasing polygenic risk score. And so what you're seeing here is that, of course, as polygenic risk score goes up, the odds of developing prostate cancer go up, but also there's this double stratification where even a higher risk for patients who have, say, BRCA1 or BRCA2 mutation. And so even within patients with, say, a BRCA2 mutation, the polygenic risk score still provides additional information. On top of that, they showed that actually you're less likely to have a high score, a polygenic risk score, if you have a BRCA2, say, mutation. And so there's this field is, and this is just in the last like 6 months this was published, so we're still constantly learning about these different facets, but they're really, really important. So one of the big questions we ask is, okay, so if I see a patient with localized prostate cancer, what are the odds that they have one of these germline mutations? And we have pretty good estimates from a bunch of studies. BRCA1 is about 0.5%, BRCA2 is about 1%, ATM also about 0.5%. Many of these are more common and lethal than non-lethal localized prostate cancer. Dr. Gamella showed one paper. And there are differences also based on ancestry. And this is another very, very recent paper. I wanted to put it up here. I knew that the figure doesn't translate very well in a presentation. It's a great paper, highly recommend it. Take it if you want to deep dive into this. But the colors are a little bit challenging to sort out, I'm sure, looking at this. But I'll spend a little bit of time to try to walk through this. And I don't know, does this mouse work? No. So the upshot is, if you look, say, on the left with BRCA2 up, which is the top two bars are showing patients of European ancestry. The top one is cases, overall cases, and the next one is aggressive cases. You can see it's around like 1% of cases overall and 1.5% of aggressive cases, so kind of like you'd expect, BRCA2 is more likely to be mutated in patients with aggressive disease. If you look on the right figure, the same two bars, they're dialed back a lot, and so that's patients of African descent. And so it's illustrative, I think, of how there are differences based on gene all the way down. It's illustrative of how there are differences based on ancestry. And so we can use this type of data and say, okay, going down, and what are the odds of an ATM mutation in somebody with localized prostate cancer? Again, it's about 0.5%, and so on. And so I think this is important for me when I talk to patients, because when we're talking about genetic testing, somebody say who has a Gleason 9 cancer, maybe they've got a family history of breast cancer, and we're talking about genetic testing, and a patient, I think many of you have probably found if you broach this topic with patients, most times maybe the patient assumes they have a mutation, right? I've got prostate cancer, it's aggressive prostate cancer, I'm sure I've got a mutation, but really, odds are that they don't. And I think it's really important to kind of convey these nuances, and we'll talk more about that. But having some sense of the likelihood of each of these mutations is really important. So which prostate cancer patients should undergo germline testing? And Dr. Gamella showed a slide on this. There are many separate different guidelines. The one that I tend to point to is this genetic familial high-risk assessment of breast, ovarian, and pancreatic cancer. It's also very much in line with the Philadelphia Consensus Conference, and it probably derived a lot of the prostate cancer information from that consensus conference. You say, well, how come it doesn't even mention prostate cancer in the title? And so would I. It doesn't, but it has a ton of prostate cancer recommendations in there. So it's a really good spot. If you use NCCN guidelines, it's a great guideline for this topic. Dr. Miller kind of went through this. It's what we think about by tumor characteristics, certainly metastatic. Also, introductal or cribriform increases the likelihood of a germline mutation risk. We talked about by family history, ancestry. And, we can try to memorize all these. In reality, I think the way that a lot of us apply this is, okay, the patient's clearly got a strong history of breast and ovarian cancer, breast or ovarian cancer in the family. Patients clearly have got a history of prostate cancer. We know many people don't know their family history all that well. And so know this, know these cancers are important. I don't necessarily recommend that you need to have that guideline up in your clinic room to look and reflect. But if you see that family history there and it crosses your mind, it's probably a good idea to broach the topic. And again, if a patient, say, has a somatic mutation, we saw the key slide that Dr. Gamella showed, the differences between somatic and germline. But if you do somatic testing and you see a mutation that looks like a BRCA2 mutation, the patient may also have a germline BRCA2 mutation, and so we recommend germline testing there. If you look at the NCCN prostate cancer guidelines, there's actually been a big effort to synergize these guidelines between the two, and they're pretty darn close. This is kind of the big picture, high-level view. Low and intermediate risk patients, we recommend germline testing if there's a strong family history or introductal or cribriform histology. We recommend germline testing in general for patients with high-risk prostate cancer or for metastatic prostate cancer. So again, what happens when we deploy germline testing in our clinical practice? This study shows, about 17% of the men tested with prostate cancer, and this included localized and metastatic prostate cancer patients. About 17% were found to have a germline variant, and then it shows the relative incidence of each of these mutations. And if you look down the line, I've kind of put up here that Colin Pritchard and colleagues study. So that was an advanced prostate cancer cohort. If you kind of compare the relative frequencies of each of these mutations, it's pretty similar. Right, so what are we going to find? We're going to find a whole lot of BRCA2 mutations. We're going to find CHEK2 mutations, ATM, and then it starts to go down after there. Okay, so how do we do it? I'm curious, how many urologists are here? Great, so mostly urologists. Any other clinicians? Okay, and how many of you do the pre-test counseling of germline, genetic testing with your patients? And then how many would just refer to genetic counselors for discussion? Yeah, okay. And so, first of all, I'd say both are absolutely appropriate. I think we've all found that access to genetic counselors can be very difficult, especially depending on where you live. And probably found that oftentimes when we make that referral, maybe there's a 3-month delay, the patient doesn't make the appointment, and not all patients end up kind of going through and meeting with a genetic counselor. So one approach is, and so Dr. Gamella mentioned, in their clinic they're very, very closely integrated with the cancer genetics folks, make that referral. But another way to approach this is for us as clinicians to perform the pre-test counseling and discuss this with patients. Now, how do we do that? Well, we need to define the criteria for testing. We talked about using NCCN guidelines or the Philadelphia Consensus Conference guidelines. Taking a good family history, we'll talk about that. Talk about how we counsel patients. Have some understanding of insurance coverage and fixed out-of-pocket costs. Dr. Gamella showed a slide with the different testing options, for example, and just about all of those have some cap. Some cap for the patient out of cost. We order the test, And then you can send to genetic counseling if they have a positive test or a variant of uncertain significance. So how do we do family history? Well, we have to go beyond just, do you have a family history of prostate cancer? I'm not saying you have to take a whole family pedigree, but we have to take a little bit deeper dive than that checkbox family history of prostate cancer. When we, this is a pretty simple form. This is what we use in our clinic, but it covers the relevant cancers, the ones that we feel are relevant to prostate cancer, and we're looking at age of diagnosis, and then we're asking about what, do they have metastatic cancer? So again, we can't just our notes can't just be like no family history of prostate cancer and move on. We have to know more. What else do we need to do? So again, we have to identify patients. We're going to explain the purpose of the test, right? So we have to. This doesn't have to be the longest discussion, but we do need to cover this ground. What's the purpose? Why would we do this test? Why are you a candidate? How accurate is the testing? Well, the answer is it's pretty darn accurate. Nothing is perfect, but it's pretty darn accurate. We have to review possible testing outcomes, and so that means, like any test we order, right? And we're going to say, well, it's most likely it's going to be a negative test. About 80% of patients are going to have a negative test, even those at risk. There's a chance, maybe a 10 to 20% chance we're going to find this variant of uncertain significance. That's a gray area. Dr. Gamella covered that. Turns out most of those eventually get reclassified as benign, so it's not pathogenic. And yeah, there's a chance we're going to find a germline mutation, and we'll talk about what we're going to do about that if we do, maybe a 10% chance. So discuss testing options, we'll talk about that a little more. Discuss genetic discrimination risks, and Dr. Gamella covered GINA. We give everybody a little bit, small brochure about GINA. We mention it, we cover that ground, what the impact is for, let's say, life insurance, disability insurance. We have to have that discussion. We can't just order the test without mentioning that, discussing that, because that has an impact for them well beyond our clinic room. And then we order the testing. Of course, as an ordering provider, it's our responsibility to discuss results with the patients. And then we talk about how that might impact the prostate cancer. Talk about screening recommendations for other malignancies. This is where we get all of these patients with a mutation. We'll talk about this again. Go to see a genetic counselor. They get additional counseling about this and about cascade testing of family members. We also give this little handout to all of our patients who are undergoing genetic testing. This is a registry. It's a national registry of patients who are undergoing genetic testing. They can enroll if they're willing to contribute their data to this effort. It's really important, and Dr. Cheng will also, I think, talk about another really important registry/program to also collect this type of data. So most patients, I think you'll find, are really willing to contribute to the science, and this type of work is really important. So what are the logistics? Well, it's usually a blood or saliva test that gets ordered. We can do a single gene, but virtually, unless there's like a known mutation in the family that needs to be tested for, we do panel testing, includes the basic genes, usually roughly around 20 genes. Talk about it could be positive, it could be negative, it could be a VUS. How are we going to handle that? And this is a word of caution, which is, if you start doing this, if you're already doing this, you're going to have the opportunity. Say, you're using company X, and they're going to come to you and say, well, you can get the standard prostate cancer 20 gene panel, you can do the 80 gene panel, and it's going to be the same cost. It's all going to be covered. And so this is a real word of caution, because I would ask you, what are you going to do with that additional information? Are those 60 genes actually relevant to prostate cancer? Do we have the data? The answer is usually not. Usually we don't have that information. And so it becomes like the further away we get from the core, 20 or so genes that we know have a role in prostate cancer risk, the further away we get from being able to really use that information to counsel our patients accurately, the more likely we are to create anxiety, the more likely we are to find a variant of uncertain significance that then again creates anxiety. And so a word of caution to really think carefully. And we don't use those other, we get those opportunities to expand the panel to these mega panels, and we don't do that. In terms of, when we get the test result back, we refer all of our patients with a pathogenic or likely pathogenic mutation to genetic counseling. Do we refer all of our patients with a VUS at this point? Not truly, but I will actually, I will communicate directly with, we as a group would communicate directly with a genetic counselor. What do we think about this VUS? Is this someone that maybe needs to see genetic counseling or not? a big caveat is we've ordered the test. I've ordered the test, for example. The test is it comes back as a VUS, say BRCA2 variant of uncertain significance. At some point in the future, that VUS may get reclassified. Most of the time it gets reclassified again as benign. Every once in a while, and this has definitely happened for one of my patients, it will get reclassified as pathogenic. So that's a big deal. Whose responsibility is that to receive that information and give it to the patient? It's ours, if you order the test, right, as any test that we order. And so we need to make sure when we're working with companies, external or internal, if you have in-house labs that do this, that we have a mechanism that we are going to get that information back to us to be able to then provide that information to patients. So we've been doing this clinician, urologist, urologic oncologist, medical oncologist directed pre-test counseling for several years now. The goal continues to be, can we provide the high quality counseling to patients to really just smooth the workflow, encourage, make it easier for patients to undergo testing. And we have used validated survey instruments to measure this. So we do the counseling, patients may or may not decide to undergo testing, and then we take surveys. And here, so dark green or light green is completely satisfied versus somewhat satisfied. And you can see that, for kind of some of these domains, for example, the summary domain at the bottom, how would you rate your satisfaction with counseling overall? 90% were completely satisfied, and almost the entirety of the rest were at least somewhat satisfied. And so I think this supports the concept that we can do this. Another set of questions I'll highlight, for example, this is one I wanted to look at. It was, I understood why I was being offered a genetic test. As you can see, we're not, 60% strongly agree here, strongly agree versus agree is the light green. Doing well, potentially we can do better. I think we continue to tweak and think about how to provide information, more materials, offer additional options for pre-test counseling. I'm pleased that I had the genetic test. Yes, the vast majority were. I was happy to have the genetic test at one of my existing oncology appointments rather than in a separate appointment with the genetics team. 90% agreed or strongly agreed. So again, I think it supports the idea that we can do this, but we can't just jump in and order tests. We have to go through the process. It doesn't have to take 20 minutes, but it has to take a little bit of our time, but it makes a difference. The key, the linchpin of all of this still remains the genetic counseling team. We need to have genetic counselors that we can reliably refer to, work with. We are very fortunate also to work with a genetic counseling team that has a ton of expertise, and we can ask questions kind of behind the scenes also. And that, the nice thing is, this makes it really efficient for them. So we identify a patient, say with a BRCA2 mutation, instead of being a 3-month wait to get a patient, they're going to expedite that patient's appointment. This is a patient with a known new pathogenic mutation. It's important, and they'll get in to see somebody quickly. Well, what are the barriers? So Dr. Cheng and several other colleagues put out a great paper a few years ago highlighting some of the key barriers to doing this, to genetic counseling in general. It's access to counselors, education. You guys are here, so thank you. Time, it does take some time. There's variable insurance coverage. It's getting much better. And again, there are caps in terms of fees by most of the companies that do the testing, $200, $250, but we have to know that and know how to deal with that and explain that to patients. And then anytime, as you guys know, anytime we change workflow in the clinic, it ain't easy. Then Stacy Loeb and colleagues also put out this great paper in the last year. Just put that out here if you want to take look at another perspective on how do we address these barriers. And so there's all these same basically domains that Dr. Cheng and colleagues have described. You think about patient factors. What can we do? We need to standardize our protocols to offer genetic testing to patients. We can think about how we can work more closely with our genetic counselors in the same setting like they do at Jefferson. We need technology support, tools to assist with family history collection. There are tools out there. And so, that's, again, a key piece of this. And then this, the last, there's like direct-to-consumer online counseling services through commercial vendors, for example, that's okay. And so there are many, many different creative approaches to making this easier. So I would encourage you to think about this and think about how it might work in your respective clinics. And so the last piece of this, again, is like, okay, well, now we've talked about implementing the testing. Well, what are we going to do with the information? Should we treat low-risk patients differently? Patients with low-risk prostate cancer differently if they have a BRCA mutation, for example, or another one of these mutations in the DNA damage repair gene? Should we treat patients with high-risk localized prostate cancer differently? A couple slides that were just kind of very similar, the same. One of them is the same as what Dr. Gamella showed, just highlighting that for specific mutations, for example, BRCA1 and 2, the odds of metastasis from prostate cancer are greater. The odds of death from prostate cancer increase with one of these mutations. So here the BRCA mutations are in red. Patients without mutations are in blue. This is a cohort of patients with localized prostate cancer who underwent surgery or radiation. It's a threefold increased odds of metastasis and prostate cancer-specific mortality independent of standard variables. And yeah, here's the Ronglong and colleague study. The genes looked at were BRCA1, 2, and ATM. On the left was the entire cohort, localized and patients with localized and or advanced prostate cancer. On the right is localized only, mutation carriers in red, non-mutation carriers in blue. Clearly a difference over many years in terms of risk of progression. So yeah, at least for some of these, they predispose to more aggressive prostate cancer. And this is a really controversial study that gets a lot of play, and it's good to know about. And so this is the Johns Hopkins cohort, looking at patients on the left with BRCA1, 2, or ATM mutations. On the right, BRCA2 mutations, mutation carriers in red, non-mutation carriers in blue. These are patients on active surveillance. This is the kind of, we know about the Johns Hopkins long-term active surveillance cohort, generally a lowish risk cohort. And on the y-axis is cumulative incidence of any upgrade. And so you'd look at this and you'd say, wow, there's a big spread. And one way to interpret these data would be to say, boy, I'm not, especially with BRCA2, I'm not sure if a patient with low-risk prostate cancer, for example, and a BRCA2 mutation should be encouraged to do active surveillance like the rest of our patients. And I would definitely urge you to consider that the jury is still out on this, that if you look at the number at risk, especially, so look at, on the figure on the right, figure B, the number of mutation carriers at time 0 is 11. We're talking about 11 mutation carriers. And by your right, starts to drop off over time, some due to censoring, some due to upgrading. And so I would really, we think, boy, is this enough to change guidelines? Of course it's not enough to change guidelines. It's important. And so how do I handle it? We can talk about how you guys would recommend handling it, but how I handle it by saying, boy, you've got a BRCA2 germline mutation. We know you're at risk of developing more aggressive disease, cancer over time, but in my view, you've got low-risk prostate cancer. You're still eligible for active surveillance, and in fact, generally encourage those patients still to strongly consider active surveillance, but with very close follow-up, knowing that they are at risk of upgrading. But again, upgrading is something we can catch, and still, we do active surveillance very closely, so that when we see upgrading, then we move on to treatment. And another way of kind of supporting that, I think, is to look at this recent study from the past collaborative, the prostate cancer active surveillance study. And so this is a long-standing registry. Patients on the left are the ones who had grade reclassification. Patients on the right are patients who had no grade reclassification. All these patients underwent germline testing. You say, okay, well, what's the, what are the rate of finding some mutation in a DNA damage repair gene? And it was greater in the grade reclassification cohort, 6%. This is the third line down, versus 3%. But almost all of that was due to mutations in CHEK2. You'll see second line from the bottom, which doesn't necessarily really predispose to more aggressive prostate cancer. And if you look at the rates of BRCA1, 2, or the bottom line, BRCA1, 2, or ATM mutations, it's identical in the two halves. And so the conclusions from this study are actually finding clinically significant germline mutations in an active surveillance cohort it's a pretty rare event. And at least in this study, it really did not seem to be big differences, if any, between patients with and without grade reclassification. So we say, what's the impact in patients with localized prostate cancer? Well, if they have low-risk cancer, is active surveillance still appropriate? And I think, in general, absolutely. With a slight asterisk, close follow-up for patients with BRCA2 mutations. For patients with high-risk prostate cancer, these patients have aggressive prostate cancer. They need the best we can offer them. They need clinical trials. They need multimodality treatment. They are absolutely at a higher risk of progression, and we need to address that appropriately. So to conclude this talk, that we know this is complex. We need to become experts. It's really important in our practice. Again, you guys know this, and thanks for coming. We need to be able to convey the pros and cons of testing, which means understanding it ourselves. And at this point, you say, well, what? Because the patients will often say, well, okay, is this test going to change my management? Do I need the test like right now when I see the patient at their initial, the new patient visit? Answer is no, until we have a clinical trial that's in the neoadjuvant space, which hopefully we will soon, thanks to Dr. Cheng. The answer is no, it's not necessarily, it's not going to impact your management in general right now. And I actually will usually defer that, I'll kind of introduce it and then say, okay, after we get you through treatment, if the patient's going to have treatment, we're going to have that discussion again. But it's really important for understanding their longitudinal risk of progression, and it's really important for their family when we think about cascade testing and testing family members of those patients. It can have an impact on sisters, brothers, sons, daughters, and so on. So with that, thanks again. Appreciate it. We have a few minutes for questions, if there are any. Yeah. Frost, come to the mic, Dr. Petros.
Thank you, great talk. Firas Petros, University of Lido. So I have patients that I reported again and digging in their family history, negative family history for cancer. You send for germline testing, they test positive, including BRCA2. I think I have 1/3 of I looked at my own patients. So have you had this experience? And then
Yeah, absolutely. So these are, right, these genes they're not totally 100% penetrant. So not everybody, and this is important for when we get into the cascade testing, not everybody with one of these mutations will develop prostate cancer. It's just we know that, and Dr. Gamella showed that the risk of prostate cancer being like 8 times greater for somebody with a BRCA2 mutation, but it's not 100%. That's important too.
Great talks. Yeah, it's very overwhelming because trying to apply all of this information in a very strategic manner, in the talks, I think we're going to need more and more knowledge and education. You mentioned the 23andMe not being more recreational. I think I was in a talk where maybe you'd mentioned color.com. Is that a legitimate testing one?
Color would be considered a medical test.
Okay.
Ordered.
They kind of get around this, right?
Yeah.
They have a little
There are
trick.
some, I think now there's a component of it that does have a recreational component, but the primary cancer predisposition panel is done with the ordering provider. So there has to be a physician ordering the test for medical purposes.
Okay.
But the trick is that they have in-house providers
they all-
who will place the order. So that's how they get around
and
that.
there's also genetic counseling that is associated with it.
And though we'd like to try to make this black and white, obviously there's just so much variance to it. If a family member is BRCA2 positive with a history of ovarian cancer or whatever, and the patient is negative on the testing, can we assume that their risk, what do we say about that?
I would say you would need to understand the full family history. There are families who have cancer on both sides of the family, so just testing, one side is not necessarily sufficient. So the context really matters.
Okay, thank you.
Dr. Lee.
Hi, I have a question. Amazing talks. Thank you. I have a question more on a population level. There's significant disparities between have-nots and the haves in terms of screening, diagnosis, and treatment for prostate cancer. Do you see precision medicine as furthering the gap between the haves and have-nots because of the costs available as well as the information?
Yeah, great question. I suspect Dr. Cheng has some thoughts on this.
I could, yeah. I think that's an excellent point, and I think, a lot of the responsibility that we have as we get educated and as we begin to move forward and implement is to really be thinking about how we are not leaving people behind. And I think that's, all of us here on the panel, hopefully you in the audience, can be moving forward with that lens in mind, because it is a really critical responsibility that we have. And I think Dr. Gamella and Morgan alluded to it, but a lot of, for example, the representation in the databases is not representative. And so the likelihood of finding a variant of uncertain significance is higher because there's less data. So we need to sort of really be thinking about that, but we also need to be doing it thoughtfully, because there has been historically mistrust, missteps, things that were done incorrectly that have jeopardized our ability to do this. And I think we really need to be thinking about it together and really engaging patients to figure out how we can do it more effectively for them. We can go in with really good intentions, but the receiving of that intention may be different, and the experience may not necessarily be one that fosters, in partnership. So, but great question.
A really important question, I think. So we need to take that snippet and send it out on the Twitter sphere, and everybody needs to hear that conversation. Thanks. Take one more question before Dr. Cheng's talk.
Hi there. Thank you for doing this talk. It's a topic that can be a little intimidating, so as a friendly neighborhood urologist, I appreciate it. My wife's actually a breast surgeon, so she's sort of appalled at how our institution treats prostate cancer genetics, so this also helps me with standing in my family, this talk.
Good. You're welcome. That's most important.
Very important. Thank you. I have two quick questions. One, maybe not quick. One question is about screening. So there are a lot of Ashkenazi Jews in the area that I practice, and I will get a lot of patients who've already been tested, maybe a cascade, maybe something else, and they want to know how I'm going to change their prostate cancer screening. That's my first question. My other question is, this is from my wife's experience. At our institution, they're trying to move away from big panel testing to really focusing only on the mutations relevant to the patient's cancer. My wife's department's trying to push back on that, but that's where we're at, and I wonder if you had any thoughts on those two issues.
Yeah. So I would say in terms of the screening question for an Ashkenazi Jewish population, I think we know that people who are of Ashkenazi Jewish descent are more likely to have these mutations. That said, if a patient has undergone germline panel testing, then that's a really important data point, and I would use that to reassure those patients. I would also closely look at family history. If they have a strong family history, well, again, I showed that initial slide, that family history is still really important. And if they have a strong family history, then I would definitely start thinking about a little bit more intensive early detection program, and maybe starting in age 40 to 45, and using, say, a midlife PSA with a 0.7 or 1 cutoff to inform intensity of screening beyond that. If a patient doesn't have that family history and they don't have a germline mutation, are they still at increased risk because they're of Ashkenazi Jewish ancestry? I doubt it. I mean, I don't know, but I doubt it from my understanding of the lay of the land. I'm so bad at the two-question thing. It's like, give me again. It's like, it's gone.
Would you, for example, screen a patient more often if they were BRCA2 positive?
If they're BRCA2 positive, yeah. So that's where we have a program, and at Jefferson too, and at University of Washington. So patients who's positive for BRCA2 mutation, we get them in for screening. They're eligible at age 35, probably age 40 is okay. We use a lower cutoff of PSA of 2 before the age of 50, and PSA of 2.5 above age 50. But we're doing this on a study, so I wouldn't say this is the gold standard. We don't know the gold standard yet, but we've got programs. There's a program at National Cancer Institute where they'll actually fly the patient out. They can get an MRI for free. It's all covered. The trip is also free, and so the answer is absolutely those patients need close screening, and we're working on figuring out what the answer is, but probably lower PSA thresholds.
The second question was about tailoring genetic testing to the patient's malignancy. and
Yeah.
whether or not you guys think that's a good idea. It's a debate at my institution.
Yeah, I think that's actually a really good point, and I think, maybe as we move forward, we can be a little bit more sophisticated about this with time. My own view is it really depends on the context. So in the metastatic setting, somebody has pretty severe disease, and I'll talk about it in a moment, really many treatment options, and so you can allow being more permissive because somebody has a strong phenotype. And so maybe, limiting not just to BRCA1 or 2, but other cancer predisposition gene. That's an affected person. In an unaffected person, no cancer with a risk. Unless you're cascade testing, I don't think it's probably worth doing, the kitchen sink. In that situation, we probably want to only focus on single gene, very high penetrance mutations. And I would argue probably not reporting VUSs because that's what causes a lot of the headache. Right, so if you're thinking about population screening, then really focusing on the heavy hitters and removing the ambiguity. But that's another longer discussion. It's a great question.
Thank you.
Awesome, thanks. Yeah, so last up, I get to introduce Dr. Cheng, again, our guest of honor from the University of Washington. Thank you again. So she's going to talk about how to apply germline testing in advanced prostate cancer, a really, really important space.
Okay, thank you, everyone. All right, let me see if I can advance these slides. Okay, we've got our disclosures again. All right, so in the next 30 minutes or so, I'm going to cover these topics. So what proportion of patients with advanced disease have germline mutations predisposing to prostate cancer? What therapies may be applicable for germline DNA damage response patients with metastatic disease? What are the mechanisms for targeting DNA repair, and what trials are ongoing in DNA repair deficiency settings in prostate cancer? So this has really, really advanced quite a bit in the last few years in really exciting ways. So we've already covered this a bit, but I just to sort of remind you, and those of you who may be joining us now, the role of genetics and genomics. So there's kind of on the left side, the inherited risk. So what is the risk of developing cancer? Those are things that we use family history to consider, and can be tested with saliva or blood. And then also using these same tests in many ways as biomarkers for treatment or management. So are there targeted treatments or targeted management plans for your cancer? And then in the middle is this decision-making and genetic counseling and the importance that we have. And then, of course, as we've mentioned, risk of other cancers. So even if your patient has localized low-risk disease and it doesn't necessarily change their prostate cancer management, it might offer options for cancer screening, for example, for attentiveness to skin for melanoma, or colon cancer screening in some cases. So that's also important. And then, of course, thinking about cancer risk in family members. So this is another schematic, and I'll show it again in this sort of general format of how I think about prostate cancer and the disease spectrum and germline relevance. So on the left side here is early detection. We've talked a little bit about that. There were some great questions. And then active surveillance, Dr. Morgan covered, and then definitive treatment, surgery versus radiation plus or minus androgen deprivation therapy. And then kind of at the far right is kind of where as the medical oncologists were sort of most active. And these include disease states such as biochemical recurrence, non-metastatic castration-resistant prostate cancer, metastatic castration-sensitive prostate cancer, and metastatic castration-resistant prostate cancer. So that lower orange box is really where most of the action is at this point in terms of where the trials are. But I'll also mention that this is these discussions and the treatments are being investigated further to, or the clinical trials are moving towards the middle, which is really exciting for patients. We've already talked about 11.8% or so of men with inherited mutations are found in men with metastatic disease. And as mentioned before, many of them don't have a family history of prostate cancer, or sometimes no family history of cancer at all. And so these are really important moments in terms of our ability as providers to really make an impact both for the patient and for their family. And these, of course, when they are germline, are known and suspected cancer predisposition mutations. Okay, so here's a table of germline mutation prevalence across disease states. So starting at the top is the metastatic disease setting, 10 or 15% depending, or up to 15%, 16% depending on the theories. And then metastatic hormone-sensitive prostate cancer, there was a paper a few years ago, 9.4%. And then in the intermediate and high-risk localized disease setting, upwards of 9.5 or 10%, in the localized disease lower. Biochemical recurrence is tricky because it's a really heterogeneous population. But these are some proportions that you can quote for patients. So here's the treatment toolbox for advanced disease. It's actually grown quite a bit, even in the last few years since I've given this talk at this meeting. So in the advanced disease setting, we have ADT, abiraterone, docetaxel, apalutamide, darolutamide, sapulocil-T, enzalutamide, cabazitaxel, radium-223, and the newest kid on the block is number 10, lutetium, which was just FDA approved not long ago and has this crazy name of vipivitide tetraxetan, so try to say that 3 times fast. So exciting. And then in the bottom is the biomarker-directed toolbox. I guess you could argue maybe that the PSMA-targeted therapies are also biomarker, but genomically biomarker-driven, and that's we've referred to already pembrolizumab, which is the immune checkpoint inhibitor, rucaparib, olaparib, both of which are PARP inhibitors, and then and carboplatin, which is an older chemotherapy. All right, so DNA repair defects in prostate cancer, Dr. Gamella has already introduced this. We have different families or teams of what I would call quality control teams in maintaining the integrity of our DNA. So one team is the homologous recombination DNA repair team, and that team is responsible for identifying and correcting double-stranded DNA breaks. And then mismatch repair is when the A to G and G to C and A to T sort of pairings are not matched correctly. And that's a different team of DNA repair genes or quality control teams, and that's the mismatch repair. And so those result in different types of mutations and are associated in different proportions in the metastatic setting. So as has been mentioned before, in tumors, there are about 20 to 25% of cancers of metastatic disease that have mutations in homologous recombination DNA repair, and those are BRCA1, BRCA2, PALB2, ATM, CHEK1, CHEK2, although there's some nuance there, and about 12% of them exist in the germline. So those represent what we've talked about, the inherited cancer predisposition. And then on the right is the mismatch repair, which is approximately 5 to 7% in the metastatic setting, and then maybe 3% in the localized disease setting, and 20% represent Lynch syndrome. So not as common, but certainly important to know about. And the treatment implications I'll talk about further, but for the homologous recombination would be PARP inhibitors and platinum, and then for the mismatch repair would be immune checkpoint inhibitors. This is really quickly, I won't spend a lot of time on this, BRCA2 mutations in response to carboplatin-based therapy, which is actually, we talked a little bit about the breast cancer field, so breast cancer, pancreatic cancer, other cancers associated with homologous recombination do use platinum, and we haven't historically for prostate cancer, but it looks like it's very effective, especially for patients who have BRCA2 mutations. And then the phase 3 PROfound study was reported not long ago, studying olaparib in the setting of metastatic castration-resistant prostate cancer. There are 2 main cohorts. There are the varsity cohort, which is BRCA2, BRCA1, and ATM. Those are the gene mutations for which we have more stronger evidence that there's a likelihood of response to PARP inhibitor. And then there was also another longer list where we're sort of still learning. So these are genes we're really interested in, we think are involved in DNA repair, but we're not as certain about their ability to predict. And those include BARD1, BRIP1, CDK12, CHEK1, CHEK2. You can see the list there. And the design of the study was really to look at the 2 cohorts. It was a 2-to-1 randomization for olaparib versus physician's choice in the metastatic castration-resistant setting post-abiraterone or enzalutamide, and the patients must have had one of the mutations, of the qualifying mutations in order to participate, and they were stratified by prior taxane and measurable disease. So very quickly, the 2 panels on the left are the cohort A, which again is BRCA1, BRCA2, and ATM, the sort of varsity team. And then on the right is A plus B, which is the entire cohort, both the varsity and the junior varsity team. And there was both a difference in imaging radiographic progression-free survival as well as overall survival. And on the basis of this, the FDA approved olaparib in 2020 for both cohorts, actually. And so this is a nice option for patients with advanced disease who have mutations in any of these genes, although the next slide sort of points out that there's more to it, and we have much more to learn. This is the paper from Johan de Bono and his colleagues that was reported from the PROfound study, and it breaks it down by genes in cohorts A and B. And so I just draw your attention to BRCA2, which is that red arrow, and you can see very clearly olaparib is better. Whereas in the yellow arrow, there's another gene which actually was not included in the FDA approval, PPP2R2A, which is that did not have any benefit. And then most of the other genes are kind of in between, and they do cross the 1.0 line. And so I think that this suggests that we have more to learn about each of these genes individually, and some of this reflects the fact that they're just very rare. So we just need more experience. On this next slide kind of makes that same point, and this is from rucaparib. So this is from the Triton-2 study reported by Dr. Abita and all and his colleagues in 2020, looking at individual genes and their response to rucaparib. And the point really is kind of the same point, which is we're just going to need to also look very carefully at each gene by gene. In this study, there was limited radiographic and PSA responses in men with alterations in ATM, in CHEK2, and CDK12. However, there was a response observed in PALB2, BRIP1, FANK-A, and RAD51B. So we just need to learn more by individual genes in addition to by category and group. And we'll be able to do this with more time, I think. So in February at GU ASCO, we had two really important studies that reported out phase 3 studies, one called PROPEL and one called Magnitude. Both of them, interestingly, were studies of abiraterone in combination with a PARP inhibitor in the frontline metastatic castration-resistant prostate cancer setting. There was radiographic progression-free survival benefit in both of the studies for the homologous recombination repair-deficient cohorts. However, what was really, I think, compelling in terms and sort of hypothesis generating and intriguing was that for the unselected population, meaning those that did not have homologous recombination DNA repair mutations, PROPEL showed a benefit, whereas Magnitude did not. So I think there's more to learn on this. This is kind of certainly an intriguing kind of finding, and I think we'll wait and see. There's more biomarker reporting that's anticipated as well as overall survival. So definitely food for thought, and I think we're all kind of really eager to see kind of the follow-up data, but definitely kind of exciting for patients, both who have mutations and then intriguing for those who don't. So next directions, I think I've made hopefully an argument for gene-by-gene assessment. We've sort of talked about the disease spectrum in terms of risk, metastatic potential, tumorigenic potential, the treatment response. So just taking germline BRCA2 as an example, we know that it increases the risk of developing prostate cancer. It may increase the tumorigenic potential and metastatic potential. We think it predicts PARP inhibitor and platinum response pretty well, and we know that a mechanism resistance is BRCA2 reversion. I didn't really talk about that, but we know that to be the case. And so can we fill in the gaps for all the other genes? Can we begin to put together the information for ATM, for CHEK2, for PALB2, and so forth? And with the goal overall of saying, can we find cancer earlier if we think there's a higher risk of developing cancer? And then can we use targeted therapies in a more thoughtful way earlier to change the natural history? And isn't that really exciting? And I hope you agree that the answer is yes. Okay, so really quickly on pembrolizumab, the mechanism of action. PD-L1 is a molecule that interacts with PD-1, and together they inhibit T cell killing of a tumor cell. So essentially, the way I describe it to my patients is this is a mechanism of putting the brakes on the immune system so that the immune system doesn't go out of control. The immune system has different checks and balances, and this is one check. If we take that brake off, we give the immune system more leeway and flexibility to do what it normally wants to do, which is find threats and take care of them. And so blocking this pathway can increase the visibility of the immune system and the sort of attention that's given and allows the cancer to be better managed by the immune system. So this is really exciting. We know that MSI high, we've talked about already, mismatch repair deficiency, as well as high tumor mutational burden can all be predictive of response. MSI high and mismatch repair deficiency are relatively uncommon, but they're really actionable. And when they do work, they work quite well. This is a series from Dr. Abita and his colleagues at Memorial Sloan Kettering reporting on the prevalence. In prostate cancer, about 3.1%, and then about 20% of them are germline Lynch syndrome patients. And then, interestingly, at least some significant portion, 5 out of 11, had really durable response. So when it works well, it can work really well, and this is really gratifying to see as a clinician. This table gets out of date really quickly, so the most important thing is that there's more trials, and clinicaltrials.gov can give you updated opportunities, but there's a number of different studies that are ongoing now in the metastatic hormone-sensitive setting and the biochemical recurrent setting. That's the bottom one, BRCA away, is actually going to be reported at ASCO in a few weeks. So this landscape is changing. And so one of the things we talked about earlier is what is the role for germline testing in the localized disease setting? And I would argue one reason to consider it is to help patients learn about their clinical trial options. And there may be some of these really exciting options for them targeted in an earlier disease setting. A brief mention on vision. So the phase 3 vision study was reported last year at ASCO. This is lutetium, now called Pluvicto or Vipivitide Tetraxetan. It was approved in March this year for patients with metastatic castration-resistant prostate cancer after AR targeting therapy, after docetaxel with PSMA expression. I think this is a really exciting molecule. It's basically radiation therapy that's tagged to an antibody that recognizes prostate-specific membrane antigen and obviously has a survival benefit and has been approved, so it's now a new agent. So one of the questions I'm interested in, and hopefully you are too, is what are the responses for germline BRCA2 and other DNA-damaging repair mutation-related cancers? Because radiation is another form of DNA damage. So one might hypothesize that patients might respond better, although there's some I think conflicting early case reports, one that says poor response, one that described exceptional response. So I think again we need more data and experience to be able to say gather more experience and move that forward. And just so you can appreciate kind of the movement in the field, this is a figure taken from a presentation from Dr. Sandhu at 2020 at GU ASCO. Radiopharmaceutical combinations are coming fast and furious. So in the neoadjuvant setting, in the first line, in the second line, and in combination with other agents such as, for example, PARP inhibitors and AR targeting. So lots and lots of excitement and possibilities for us moving forward. And then I would sort of posit that it's important for us as a field to gather better data and to do so together. And we've talked about some therapeutic clinical trials already, but I think also assembling our experience and data in terms of registry studies. So even if somebody does go on a study or they go on 3 studies, we want to know sort of longitudinally how do they do, and for those who can't go on studies, what is their experience? And so this is the PROMISE study, which has 2 main objectives. One is to offer germline testing for patients. The testing is saliva-based. It's color, we talked about that as a platform. It's mail-based, meaning you can participate from the web and from your own home. And that's another option in terms of getting access to testing, and the testing is covered by the research study, so the patient does not have to pay anything, and insurance is not involved. So this is an option for testing, but the second more important, I think, or equally important objective is also for long-term follow-up. So those who have mutations of interest in the genes that we've talked about, BRCA2, ATM, and so forth, are also invited to long-term follow-up, and we plan to follow them 10, 15 years out to see what their outcomes are. And this is for any stage of disease, so localized, active surveillance cohort, definitive treatment, and then advanced treatment if relevant. So that's that schematic. So conclusions. So 1 in 5 patients with metastatic castration-resistant prostate cancer have DNA repair mutations in their tumors, and 1 in 10 with advanced disease carry one of those mutations as an inherited form, which has really important implications for treatment as well as family counseling. And so offering genetic testing is really recommended for now many patients with prostate cancer, and that's, what we've been talking about for the last 2 hours. Molecularly targeted precision therapies are now approved, so it's not, it might happen, it is here. They're available for patients, and they include pembrolizumab, rucaparib, olaparib, and carboplatin for advanced disease patients. And there's many trials. I hope you had a sort of appreciation of what's now coming, of combinations and also these agents in earlier disease states. Gene-by-gene interrogation and longitudinal registries, I think, are going to be also really important as we move forward. I didn't mention here, but I'm just going to, or I don't put it here, there's another registry that Dr. Geary has called Precision, which is looking specifically at patients who are getting PARP inhibitors, and I think that's also really exciting, and I'm happy to share that with you after. And then urologists, you in the audience here today, urological oncologists, and together with genetic providers, medical and radiation oncologists are really going to be a key part of realizing this potential for patients and for the knowledge that we can gain in the future. So I'll just end with this schematic that I like to show, which is a shared vision of cascading impact. So this is sort of from a medical oncologist standpoint. So I'm looking, these are the 10 patients with metastatic prostate cancer, and some of them are candidates for PARP inhibitor platinum and pembrolizumab. And 1 in 10 of those men carries DNA repair mutations, and 50% of their first-degree relatives may carry these same mutations. And they have, women have tailored screening and risk reduction options, and we are hoping to get more options available for tailored early detection and curative intent. I've listed some of the early detection efforts, and we've mentioned them earlier. Also, Dr. Morgan has that program at University of Michigan and at Philadelphia as well at Jefferson. And so these are things we really need to be working on together, collecting and assembling knowledge to advance opportunities for tailored management at every stage throughout this spectrum of disease. So effective integration of genetics and prostate cancer clinical care can be a force multiplier against cancer. So that's my last slide. Happy to take questions with the rest of the panelists. Thanks.
Please go ahead. Thanks. Great talk, Heather, by the way. Thank you.
Yeah, I got a couple of questions. I'll just do them kind of one at a time about the polygenic risk score. It really seems like the literature and some of the slides that you provided suggest that instead of having 2 legs to the table, the germline genetic testing and the somatic, that the polygenic risk score may be coming in as kind of a 3rd leg to this because of the multiple allele risks that it picks up that, miss the single gene mutations, but the single gene mutations can miss the risk of the combined score. So the first question is, how do we use the polygenic risk score currently? Is there a role, or is it not clearly defined yet in terms of what we do with next steps?
So, we've known about these polymorphisms for years. It's just now that people are trying to get different racial backgrounds, genetic backgrounds of families from European, African American, and I think that's been one of the big steps forward. So we don't really have any, this is all, again, new information with the polygenetic risk scores. They're not really baked into any guidelines yet. I think they're evolving. And again, as I always like to talk about, we still do not know what causes prostate cancer. And it could be that there's something in these polymorphisms that are subtly affecting a protein or something in our body, and then that you got a DNA repair pathway and it goes. So I don't think we're there yet. I think we presented the information. I think it's going to be probably a year from now we might have more information, but right now there's really not a formal approved polygenetic risk score out there that's universally covered. Todd, would you agree?
Yeah, but it's coming. I think the key criticism, key reason I think that they haven't been more widely adopted is they're really good at predicting development of prostate cancer. They can stratify prostate cancer risk, but none of them so far have reliably shown that they're able to predict for aggressive prostate cancer in patients and unaffected individuals. And so we're always looking for the biomarker that helps us know which men to screen, and just like knowing some men are at greater risk of any prostate cancer obviously is not as informative as at risk of aggressive cancer. And so that's the critique. I suspect eventually, it's not going to be too long before we're we're all submitting to 23andMe or something like that, and we're getting our cardiac risk and our Alzheimer's risk, and potentially you could imagine that prostate cancer risk is going to be baked in there.
One question, actually, just made me think of a question for Heather. So how much are polygenetic risk scores used in other malignancies? Is there any, are they used at all?
I think my sense is, talking to my breast and colon cancer colleagues, is they're in a similar at a similar place, which is there's a lot of interest. One of the things that the recent developments that I think is important, going back to one of the comments, is that we have now polygenic risk scores that has been validated for multi-ancestry populations. And I think that, will help ensure that the data that we have is not limited to, Caucasian or the white population, which historically had been one of the criticisms of the existing polygenic risk scores. So I think, it will be coming. I think it'll probably land more in the urology conversations for screening rather than in the medical oncology setting, although I think there's a lot of interesting biology that we can learn. For example, which single nucleotide polymorphisms might interact with the rare variants or other tumorigenic possibilities. Those are at this point academic, but from a clinical standpoint, I think it'll probably, it may be coming to urology, but,
I mean, it's, again, I'm really proud of the group of urologists here. I mean, precision medicine is our future. And I think, breast cancer is so far ahead of us that we have a lot to learn from them. But I think everything that we're going to be doing, our residents right now, we're trying to teach them more and more about genetics and genomics and how they're actually going to be applying, this is sort of like Star Trek or something with, Spock and Bones. You're going to just get a genetic profile and you're going to decide what's going to be the best screening strategy. And it's going to be multifactorial. It's just not going to be, as we pointed out, it's just not going to be the mutated genes we're talking about, but it's going to be these other factors like, the polygenetic risk scores and things like that that are going to direct our screening. Right now, again, as Heather mentioned, I think the polygenetics right now looks like it may impact screening, but beyond that, therapeutics right now, it doesn't seem to have much of a place.
Yeah, and just a comment to add to that, I mean, it's really interesting that with Germline and with Somatic, you're still siloed to just the cancer that you're talking about, but with a polygenic risk score, you get the lifetime risk of major adverse cardiovascular events, for example, which are 4 to 5 times more likely to take a newly diagnosed prostate cancer's man's life than the cancer itself. So a lot of interesting things to come, I think.
Yeah, it's a really great comment and question. Thanks. Come on.
I'm Seok-Soo from South Korea. It's a practical question. And one of my patients' somatic test was negative for BRCA1/2. And this patient is metastatic CRPC patient. So in this case, do we have to recommend him to receive Germline test?
I think if I understood your question correctly, you said the question is if there is a somatic germline test or somatic testing for MCRPC, do they also need germline testing? Is that the question?
If it's negative, the somatic testing was negative, say for a
yes.
DNA damage repair
Yes,
gene.
sorry. Yes, I would say if the patient is interested, yes, and I didn't go over that, but depending on the test, and it depends very much, and this is changing also on the test platform. So some tests will report suspicion of germline tests, and other tests, the informatics that they use will screen it out completely. So it's really important, if you're uncertain, to not assume that the somatic will identify suspicion of germline, because in some cases it does not. So I would really think of them as potentially complementary, but really, there's in the Venn diagram, there's an area that's not overlapping. So it's best, if there's interest and a family history, for the patient to also get germline testing, at least at the present time.
Okay.
Good question.
Yeah, please.
Yeah, so I have a question. I know there's no answer for what I'm going to ask, but I think it's something that's important for us to think about. I think one of the trends in treatment of early localized prostate cancer today, with all the technology that we've seen, is the ability to treat some patients, focally for their prostate cancer. And so, do you envision that, there'll be a role for germline testing specifically and sort of culling some of those patients out who may or may not be candidates for focal therapy? Is it going to be safe to leave prostate tissue if there's a germline mutation?
Love that question. There is, as you no doubt know, there's no simple answer to that. But it's a really great issue to highlight, because the bigger question is, which patients, say with higher grade cancer that we can see on an MRI, are appropriate candidates for focal therapy? And, how do we risk stratify these patients? Do I think germline genetics are going to play a role? Yeah. I mean, for example, BRCA2, right? If they have a high grade cancer, even Gleason 7 cancer, and even if it's like they're the perfect candidate, they've got cancer, they've got a BRCA2 mutation, they are at risk of developing very aggressive cancer in the future. They're at risk of dying of prostate cancer. They are not a focal therapy candidate.
No, I think it's interesting because we're limited to really phenotypics. What's it look like? What's the Gleason score look like from the view? It doesn't tell us much about the really biology of that cancer. Really, that's how much we're in the infancy here. But you can certainly, I think the ability to take a small tumor and kill it very effectively with the different energies is very good.
Yeah, we can do that.
That's not the question. I've done hundreds and hundreds of focal procedures, so I'm confident that I can kill a target if I can get energy to it.
Yeah.
But the real question is, what's the rest of the cells in that prostate? What are they going to do, and what's their potential to develop a dangerous prostate cancer as years go by, especially in a young man?
Yeah, it's such a good point. So, we're surgeons. We can remove a whole prostate. We can treat a focus of cancer. That's our thing. But from a biological standpoint, just because we can doesn't always mean that we should. And with focal therapy, my opinion is we still need to be very, very selective, because we don't yet understand which patients are at really high risk. We don't know which tests are the best tests to use. And so this is, I think, a really important area of study for anyone doing focal therapy, whether they have their own research programs or working with other places that have research programs, studying the biology of those tumors, studying the biology of the patients who have recurrences, understanding what really is the index lesion. We call the index lesion. Is it always the lesion that we can see? We know that that's not the case. Sometimes the lesion that we can see is not the biological driver of eventual metastasis. And so these are the big questions that we have to understand if we are going to go the way of focal therapy, which would be great from a patient standpoint if we can do it safely.
I think in my mind, if I'm going to offer focal therapy to a patient, I think I do want to know their germline status, because if we proceed with that, I think it would clue me into making sure that patient is followed very, very carefully.
Yeah, that makes a lot of sense.
It seems sort of analogous in a way, similar considerations to active surveillance. You want to just be either thinking about the risk and then being very attentive even if somebody chooses to move forward.
Okay, well, with that, we'll conclude this. I do want to just remind everybody about